in retinal ganglion cell death are only insult due to rising intraocular pressure and vascular insertions. The second insult is excitotoxicity. There are only major two forms of glaucomas are encountered. In that, so many varieties of glaucomas are there. Mainly, they are divided into two types. One is open angle glaucoma, and other one is closed angle glaucoma. It is other. Primary and secondary. Angle is normal. Angle structures are all seen in the gonioscope, and the depth of the antechamber is normal. Everything is normal. But when we see the optic disc, you can notice the changes. And in the visual fields also, you can see the visual field effects. This is called primary open angle glaucoma. The second primary angle closure glaucoma is the constantly in this condition there is constantly elevated intraocular pressure, and this it is due to the opposition of the peripheral iris against the trabecular meshwork, thereby closing the trabecular meshwork. This will lead to closure of the angle, antechamber angle, and obstruction of the aqueous outflow. You all know the aqueous is drained from the antechamber by trabecular mesh through trabecular meshwork, then into Schlemm's canal. Aqueous is produced by the ciliary body. And this is the diagram showing that this is a normal eyeball structure. You can see the angle here, and this is the iris tissue, and this is the pupillary area. In the eye with glaucoma, you can see there's a blockage of the trabecular meshwork. Whether it is open or closed, there will be no drainage through the trabecular meshwork, thereby building the pressure intraocularly, thereby rising the intraocular and damage to the classification of the first one is the parasympathomimetic ducts, sympathomimetic ducts, sympathomimetic ducts are adrenergic drug agonists. Parasympathomimetic drugs are otherwise myotics because they cause constriction of the pupil. And the next one is beta blockers, carbonic anhydrase inhibitors, hyperosmotic agents, prostaglandin analogs, calcium channel blockers. These are major drugs which are used in the practice of glaucoma treatment. First one is the parasympathomimetic drugs. These drugs act by contraction of the longitudinal fibers of the ciliary muscle, pull on the scleral spur, changes in the trabecular meshwork, and there will be lowering of the intraocular pressure. In case of primary closed angle glaucoma, in this the pupil is mechanically contracted. So pupil will become small, iris moves away from the trabecular meshwork, and the angle is open. Next, in this group, the most commonly used one is pilocarpine. It is used as 1% or 2%, 4% strength. in the form of eye drops. It is a directly acting parasympathomimetic drug. It is contraindicated in the inflammatory glaucoma because in inflammatory glaucomas there will be ischemia of the sphincter. So the drug will not get absorbed, and there will be no immediate action will be there with we use pilocarpine. And in case of malignant glaucomas, unknown allergies, because when the person is allergic to parasympathomimetic drugs like pilocarpine, it is contraindicated. It is available as in the form of 1%, 2%, 4% eye drops, and in the form of ocusets. In the previous class, I told you the devices are available impregnated with the pilocarpine. This device will release constant concentration of the pilocarpine, and it is kept in the conjunctival sac. And also, it is also available in the form of gel, 4%, and it should be used at the bedtime because the rate so that the patient need not put drops frequently. Next, other one is carbocal. This carbocal has dual action myotic. Sorry, it's a good alternative for the pilocarpine resistant cases. It is available in the form of eye drops. Other one is ecothiophthate iodide, long-acting cholinesterase inhibitor, available in the form of eye drops. Mercurium bromide. This is also available in the form of eye drops. And physostigmine, it is a weak anti-cholinergic drug. It is available in the form of 0.5% ointment. And then coming to the side effects of these parasympathomimetic drugs, systemic side effects and local side effects. Locally, there is a it is more frequently local side effects are encountered while using the long-acting irreversible cholinesterase inhibitors. Due to meiosis, there will be reduced visual acuity. Suppose the patient is having any polar cataracts, polar opacities in the nucleus, lenses, there will be, due to meiosis, the patient is unable to see. So the patient will get reduced visual acuity in polar cataracts and impairment of night vision, because in the night dim light there will be already constricted pupil. Patient cannot see better in the night vision, night times. And generalized contraction of the visual fields, because the pupil is constricted, patient cannot visual fields also will get generalized contraction of the visual fields. And due to constriction of the pupil, there will be the refractive status may change into myopia side, and frontal headache, retinal detachment, lenticular opacities, irisis, mild iritis. Mild iritis is most frequently encountered complication. Lacrimation and follicular. For chronic usage, patients may get follicular conjunctivitis. Then coming to the systemic side effects, first one is bradycardia, increased sweating, diarrhea, excessive salivation and anxiety. With irreversible cholinesterase inhibitors, there will be scoline apnea. That means inability to recover from the scoline, inability to recover from the general anesthesia. While giving general anesthesia, scoline is given to relax the respiratory muscles. Scoline is a short-acting respiratory muscle paralysis to give make the intubation possible. There will be paralysis. They will use scoline to paralyze the respiratory muscles. It is a short-acting. Suppose the patient is under the parasympathomimetic drugs like pilocarpine or chronic usage of pilocarpine, there will be scoline apnea. Due to this, so the patient should be asked to stop the eye drops before giving any general anesthesia. Then coming to the other major drugs group is sympathomimetic drugs. The sympathomimetic drugs act by increased aqueous outflow by acting on the alpha and beta receptor stimulation. By stimulating the alpha and beta receptors, and decreased aqueous humor production occurs due to the stimulation of the alpha receptors in the ciliary body. It is a mechanism is a dual manner, increased outflow as well as decreased secretion. Thereby, the intraocular pressure is reduced. The major side effects are locally, the patient may get burning sensation, reactive hyperemia of the conjunctiva, conjunctival pigmentation, and mydriasis. Mydriasis means pupillary dilatation. Systemically, they may get hypertension, tachycardia, headache, palpitation, tremors, nervousness, and anxiety. The major drugs under this group are, first one is epinephrine. It is a direct acting sympathomimetic drug. It will act on both alpha and beta receptors in stimulatory pattern. It is used in mostly in primary open angle glaucomas and in also secondary glaucomas. It is available as 0.5%, 1%, and 2% hydros. It is advised to use twice a daily. To instill 1 drop twice daily. And epinephrine. This is a prodrug converts to epinephrine. After instillation of the conjunctival sac, it is absorbed through the corneal epithelium, corneal layers of cornea, and it is converted into epinephrine. It is a prodrug form, and this is lipophilic. This is 17 times better corneal penetration. It is available in the form of 0.1% eye drops. As I told you in the previous class, this is a prodrug form. After absorption into the antechamber through cornea, and this will be converted into epinephrine. It is 17 times more better action than the better corneal penetration than other when compared to the other sympathomimetic drugs. And the other one is clonidine hydrochloride. This is a central acting anti-hypertensive drug. Stimulation of the alpha receptors in the ciliary body decreases the aqueous humor production. It is available in the form of eye drops. And the other one is, next one is the brimonidine. This brimonidine is selective alpha 2 agonist. That means it acts only in the alpha 2 receptors. Decreases the aqueous production, enhances the scleral outflow, so that the intraocular pressure is decreased. It is used as an adjuvant to the beta blockers. When combined with the beta blocker drug, the action will be better action. Then another one is epinephrine. This is also alpha 2 agonist, extremely potent ocular hypotensive used prophylactically for prevention of the intraocular pressure elevation following laser surgery. This is not advised for long-term usage because of high rate of side effects. And the other one is most commonly used drug is beta-adrenergic blockers. This is the most frequently used anti-glaucoma drug. It lowers intraocular pressure by beta-2 receptor blockade in the ciliary process, resulting in decreased aqueous production, good synergistic effect when combined with the miotics. This is contraindicated in systemic diseases like bronchial asthma, emphysema, chronic obstructive lung disease, pulmonary disease, heart blocks, chronic congestive heart failure, and cardiomyopathy. Because when the beta-adrenergic drugs are used, there will be stimulation of the bronchial receptors, leading to the constriction of the bronchial airways, resulting in the aggravation of the condition. So it is contraindicated in the bronchial asthma patients, emphysema patients, chronic obstructive pulmonary disease patients, heart blocks, congestive heart failures, and cardiomyopathies. Before prescribing this beta-adrenergic blockers, we should ask the patient about this history of any lung diseases or any heart diseases. The most commonly used beta adrenergic blockers is timolol. This is the most commonly used anti-glaucoma drug. It is available 0.25 and 0.5% eye drops. It is a non-selective beta 1 and beta 2 blockers. And it is available in the form of timolol maleate. The concentrations of 0.25% and 0.5% eye drops. And it is advised to use twice daily. One drop to instill one drop twice daily. In chronic usage of this timolol drug, there will be short-term escape. That means initially after starting the treatment with timolol maleate, there will be initial fall in the intraocular pressure followed by transient rise with continued moderate fall in the intraocular pressure. And the other one is long-term drift. After using this drug for longer periods, there will be long-term drift. That means marked initial slow rise of intraocular pressure in patients with many months of therapy. So there will be increased. This is because there will be receptors will be increased. So the drug is not effective. Suppose it is used for longer durations. And the other one is a bitoxolol. This is a cardioselective. We can give it with safely in the case of bronchial asthma patients and cardiac patients because it is cardioselective. It is available in the form of 0.25% and 5% suspensions. This bitoxolol it is also a neuroprotector. That means it protects the nervous tissue, optic nerve tissue. The other drugs available are levobulin, lateolol, mitoprolol. And then coming to the side effects of this timolol, one is ocular, systemic, central cardiovascular complications, respiratory complications, central nervous system, and miscellaneous. Main local or ocular complicated side effects are not that much common. There will be burning and conjunctival hyperemia. This is mainly due to that preservative used along with the drug. Preservative used along with the drug. That means while manufacturing this drug, the benzalkonium is used as a preservative. Due to this preservative, the patient may get burning and conjunctival hyperemia, burning sensation, conjunctival hyperemia, superficial punctate keratopathy. That means there will be small punctate erosions will be seen in the cornea and corneal anesthesia also sometimes. And then systemic side effects are low because the drug is used only topically. There will be less systemic side effects. Then coming to the cardiovascular complications, there are because it is a beta blocker, there will be bradycardia, arrhythmias, heart failure, and syncopes. And respiratory complications are bronchospasm, airway obstruction in asthmatics. And this is not known with betaxolol because it is a selective beta blocker. There will not be any effect on the respiratory system. So we can use this betaxolol instead of using timolol. We can use betaxolol in these asthma patients. And CNS side effects are only depression, anxiety, and confusion, etc. Miscellaneous, nausea, diarrhea, and decreased libido, rashes will be encountered with chronic usage of this drug. And then next one is main group is carbonic anhydrase inhibitors. This is a potent and most commonly used systemic anti-glaucoma drug because in severe glaucomas like the intraocular pressure is more than 30 millimeters of mercury. What is the normal intraocular pressure? Anybody? Anybody? Am I audible? Hello.
Yes, ma'am, audible, ma'am.
Yeah. What is the normal intraocular pressure? Oh, wait, somebody responded. It seems 11 to 21. Good. Suppose the intraocular pressure is raised for more than 30 millimeters mercury in the in case of it is seen in chronic, acute ankylosing glaucomas, there will be acute elevation of the intraocular pressure and it's an acute condition. It should be treated immediately. In those cases, we can use this carbonic anhydrase inhibitors. There will be immediate fall of intraocular pressure by using these carbonic anhydrase inhibitors. This will inhibit the carbonic anhydrase, which is related to the process of aqueous humor production. That means in production of the aqueous, in secretion of the aqueous humor, carbonic anhydrase is used. Enzyme is used. These drugs will inhibit this enzyme so that there will be decreased production of the aqueous. It is indicated in the additive therapy along with the beta blockers. So it should not be used in the long-term cases. That's all. It should be used only short-term because the side effects are more. It is used only to control intraocular pressure in the acute conditions like acute ankylosing glaucomas. Can be used in all types of glaucomas. And it should be used in the long-term usage only when the other anti-glaucoma drugs are failed, in treatments are failed, and there is high risk of visual loss. Then only we should use these carbonic anhydrase inhibitors for the long-term basis. Topically available carbonic anhydrase inhibitors are second-line drug and as an adjunct. Those are otherwise available in the form of drops. First one is orally we give Dimox. That means the Dimox means it is acetazolamide tablets available in the form of tablets, capsules, and it should be given orally. We can give it in the form of tablets, the strength of 500 milligrams or 250 milligrams 3 times a day or 6 times, 4 times a day, depending upon the situation. Depending upon the raised intraocular pressure, you can titrate the doses. 250 or 500 also we can give 3 times a day. And the other one is dichlorphenamide. This is less metabolic ester. There will be less metabolic esterosis with this dichlorphenamide, whereas estrozolamide there will be metabolic esterosis. Other one is methazolamide, ethoxyzolamide, dorzolamide. This is the only available topical carbonic anhydrase inhibitor. It has excellent corneal penetration, additive with the timolol. It can be used along with timolol. It is used in the 3 times a day. Burning sensation, it will have the side effects are burning sensation and local allergic reaction to the drug. It is available in the form of 2% drops. Other one is the brinzolamide. This dorzolamide is available, the only available topical anhydrase, carbonic anhydrase inhibitor. And coming to the side effects of the drug, this estrozolamide and all these carbonic anhydrase inhibitors, because half of the patients are cannot tolerate this drug because this drug has various side effects like paresthesias due to loss of paresthesias or due to loss of more electrolytes, urinary frequency, and patient will get more urination. Serum electrolyte imbalance due to loss of electrolytes in the urine. There will be serum electrolyte imbalance, so that that will lead to tremors. The main commonest complaint is the side effect is tremors. Who is that? The main side effect is tremors. The loss of electrolytes in the urine and patient is dehydrated. Patient may get tremors and increased urinary frequency and paresthesias. And there will be bicarbonate depletion leading to metabolic acidosis and malaise. Due to loss of more electrolytes, patient is may feel weak. The treatment is sodium bicarbonate or sodium acetate. You should treat the depleted by giving substitute with sodium bicarbonate. And there will be potassium depletion also sometimes. The serum sodium and chloride also reduced. All the electrolytes are excreted through the urine by giving this carbonic anhydrase inhibitors. So we should use the drug cautiously. It is only used in higher pressures to control higher pressures. And gastrointestinal symptoms like diarrhea. Then suppose the patient is toxic, allergic to sulfonamides, he may get sulfonamide related side effects if we use this estrazolamide. Then the other one is hyperosmotic agents. Suppose the patient is in case of acute ankylosing glaucoma, the patient will come with high pressures. That means more than 60-70 intraocular pressures. Should control the pressure immediately. Otherwise, the patient it will damage the optic nerve and lead to permanent blindness of the patient. Permanent blindness or permanent loss of vision due to damage of the optic nerve head. So for that cases, we should use hyperosmotic agents. The mechanism of action of these hyperosmotic agents are these increase the plasma tonicity. By increasing the osmotic pressure in the circulation, they will create osmotic pressure gradient between the blood and vitreous. So there will be shrinkage of the vitreous, and this will draw fluid from the vitreous into the circulation and sufficient water out of the eyeball, thereby reducing the intraocular pressure. There will be shrinkage of the vitreous by drawing water into the circulation. The indications of this hyperosmotic drugs are, this is also used in acute conditions to control the acutely elevated intraocular pressures as an additive therapy, and should be used in emergency conditions such as acute ankylosing glaucoma with very high intraocular pressure. And it is also used prophylactically prior to intraocular surgeries. Suppose the patient is having any lens-induced glaucomas. That means hypermature cataract and mature cataract. In case of, suppose we left the cataract without surgery for longer times, it may lead to increased intraocular pressure. That is called lens-induced glaucomas. In those conditions, primarily we can control the pressures by giving these hyperosmotic agents. And while performing surgery also, before doing surgery, it should be given, because we should not perform cataract extraction. Suppose the pressure is increased. So 1 hour or 40 minutes prior, 1 hour prior to the surgery, the patient is given mannitol intravenously. The various drugs available under this group are, first one is the glycerol. It is a oral hyperosmotic. It is available, the dosage is 1 to 1.5 grams per kg body weight. It is available in the form of 50% solution. It is contraindicated in the diabetics because it is metabolized to glucose in the body. Then, so it is not used in diabetics. And in the costlier also when compared with the mannitol. So commonly we use mannitol. It is also intravenous hyperosmotic agent. The dosage is 1 to 2 grams per kg body weight. Suppose the patient is about 60 kgs. Then we should calculate the dosage accordingly, and we should give intravenously. It is available in the form of 20% solution, mannitol. So in 100 ml of solution, there will be 20 grams of mannitol. Accordingly, you should calculate the dosage. So for 60 kgs patient, we should can give 300 ml of the drug intravenously. And the next one is urea. Other one is isosorbate. These drugs are both are not used widely. Then other most important one is the prostaglandin derivatives. For long-term usage, the patient there will be better compliance and the results will be better. For long chronic glaucomas, prostaglandin derivatives are used. For the acute conditions, we can treat the patients accordingly by using the previous drugs. For long-term usage, so once the patient is become known glaucoma patient, he need to use medication for his life. Otherwise, he may lose his vision. So he is advised to use the medication for the lifelong time. One is the most widely used one is latanoprost. This is available in the form of 0.005% drops. This is a synthetic analog of prostaglandin F2 alpha. It acts by increasing the avascleral outflow, reduction in the episcleral venous pressure. So the drainage of there will be reduction of the episcleral venous pressure. That means due to pressure gradient between the trabecular meshwork and episcleral veins, this intraocular fluid will be drained into the episcleral veins because of the reduction of the episcleral venous pressure. This is used along with the pilocarpine and timolol. The major side effect is foreign body sensation, early morning hyperemia, increased iris pigmentation, and increased growth of the eyelashes. In chronic cases, the patient may have conjunctival hyperemia. That means usually this drug is advised in the night bedtime. Only once daily instillation in the bedtime. So after chronic usage, there will be increased pigmentation of the iris, increased pigmentation of the lashes, hypertrichosis, and conjunctival hyperemia. The major drawback is conjunctival hyperemia. And the other one is bimatoprost. This is also available in the form of 0.03% drops. This also decreases the ocular outflow resistance. That means decreased avascleral venous pressure. This is also advised in the form of only once daily doses. Other one is travoprost. And the last one, there are so many drugs are available in this group. Most commonly used ones are I am telling. Uniprost isopropyl. This increases the retinal blood flow. And then other one is a calcium channel blockers. This is available in the form of drops, verapamil, drops in the concentrations of 0.125% and 0.25% drops. It is indicated in patients where all other drugs are contraindicated. Example in patients suffering from patients suffering from axial cataract, asthma, and hypertension, where all other drugs are contraindicated. Then only we should use this calcium channel blockers. It is also have an additive effect with pilocarpine and timolol. Exact method of action is not known. Might be due to its effects on secretory ciliary epithelium. It lowers the intraocular pressure. To summarize, glaucoma is a group of disorders resulting in optic nerve damage due to rising intraocular pressure, characterized by optic disc changes and visual field changes. The drugs used in the management of glaucoma help in lowering the intraocular pressure levels through various mechanisms. One is increasing trabecular outflow. That is, for example, myotics, pilocarpine. Other one is epinephrine, epiverapine. Dermatoprost. Next one,